Medurstand-Understanding Medicine.
I'm Professor Aziz Rehman, and today I'm going to start a 3-lecture series on inflammatory bowel disease, abbreviated as IBD. Now, this is fairly common condition, and there are actually 2 or 3 variants, and in this particular video, I will discuss about the introduction and the common features and a broad outline of this condition. And in the subsequent 2 videos or lectures, I will cover ulcerative colitis and Crohn's disease separately. So what is the definition? Inflammatory bowel disease, abbreviated as IBD, is a group of chronic inflammatory conditions that affect the digestive tract. It has extra intestinal manifestation also, but primarily it is the disease of the bowel. The commonest type is ulcerative colitis, where the disease is usually confined to the colon, and it is characterized by inflammation of the mucosa, and that could lead to ulcer formation also. And then we have Crohn's disease or Crohn's disease. This is a granulomatous inflammation which affects any part of the gut, but most commonly small intestine and then a large intestine also, but actually can affect any part of the gut starting from mouth to anus. And then overlap syndrome. There may be some cases which do not clearly fall in any of the 2 groups. There may be combined features. So prevalence, number 1, it is a global disease, but definitely more common in West than in our country. Perhaps it has got something to do with the diet or with the environment, or with the temperature or social status, but there's no doubt that inflammatory bowel disease, both varieties, they are much commoner in the West as compared to our country. And in our country, this disease actually tends to be milder as far as the disease extent is concerned and the severity is concerned. And in all societies, ulcerative colitis is commoner than Crohn's disease. Although recently there is increase in the prevalence of Crohn's disease, so it is catching up, so it is getting now close to ulcerative colitis. One reason why we say ulcerative colitis is commoner could also be because this condition is relatively easy to diagnose. This one is more difficult, so maybe we actually miss some cases of Crohn's disease. It can affect both genders and middle age, so it is not necessarily the disease of old age. It is the disease of maybe in 20s or 30s, and people can have this disease. There are no definite known predisposing factors. There are some factors which can actually contribute, but we do not know the exact etiology. So there is definite genetic predisposition. Those who have family history of IBD, they tend to have this disease more commonly. So, and there are some genes, some HLA antigens which have been identified as predisposing factors to these 2 conditions, like other autoimmune disorders. But I'm not going to go into the details because I consider that out of scope of my lecture, because this is basically meant for internists or physicians. So, and then on genetic predisposition, usually there is some infection, some gut infection, and that gut infection somehow triggers this disease process, probably by disturbing our gut flora. Maybe some infection doesn't get cleared off and it changes our gut flora, our microbiome on permanent basis. This is called dysbiosis, and that somehow triggers this disease, causes an inflammation that results into different clinical features. But diet is also postulated to be a contributory factor. I think main reason we suspect infection or diet as a contributory factor is perhaps because both the gut is exposed to both. So our gut is full of microbiota, and we take diet every day. So I think that is why these 2 factors are considered to be contributive, but no definite single diet and no definite single infection is known to precipitate inflammatory bowel disease. Then both this genetic predisposition with infection, with diet, that actually leads to dysregulated immune response. You know, our gut is full of immune system. That is because that is one source of possible invasion of the bacteria into our system. So gut is actually very fully equipped to counter these bacteria. So this immune mechanism gets dysregulated and leads to pathology. So that may cause what kind of dysregulation we don't know, but perhaps one type could lead to ulcerative colitis and another mechanism could lead to Crohn's disease. But we know that both diseases, they have many common features. So perhaps the etiology is the same, but something in the immune system or something in the triggering factors determines which patient would develop ulcerative colitis or which patient develop Crohn's disease and which patient would develop an overlap syndrome that I explained earlier. So this is the natural history, and then we of course give medication, and it is also postulated that some medication with diet also triggers this disease process. So with medication we try to control this condition, and since this disease is characterized by flares and remissions, so we first of all try to control acute flare. Patient comes with acute symptoms, we try to control that flare, but then we must maintain some treatment to prevent relapse because there is no curative treatment. We don't have curative treatment because we don't know exactly what causes this condition. So after achieving remission, we try to maintain that remission by giving continuous medication. So I hope this slide will give you an overall concept about the pathology and etiology of this disease. So the classification, there are people who would have clear-cut ulcerative colitis. Their disease is confined to the colon only, and the findings on colonoscopy and finding on biopsy are typical of ulcerative colitis. And there are other patients who have this Crohn's disease, and it can involve any part of the gut, and if you manage to reach the lesion by endoscope, the picture would be that of Crohn's disease, and finding on imaging, CT scan and other things and on biopsy would be that of Crohn's disease. And then we have mixed pattern. Mixed pattern means at one time some features are those of ulcerative colitis and other features are those of Crohn's disease. And these are the basic differences between ulcerative colitis and Crohn's disease. And this is just an outline. I will discuss these features when I take up ulcerative colitis in the next lecture and Crohn's disease in a third and subsequent lecture. So part of gut involved in ulcerative colitis, it is almost always only colon and the distal part of the colon. Whereas in Crohn's disease, it could be any part of the gut, mostly small intestine, but sometimes large intestine also. Type of inflammation in ulcerative colitis, it is just acute non-specific inflammation. Whereas in Crohn's disease, it is granulomatous inflammation, but not typical of like other granulomatous condition. It is again atypical granulomatous inflammation. That means you will find granulomas in the biopsy specimen. Layers of gut involved, you know, our gut has got 4 layers: mucosa, submucosa, muscular layer and serosa. And ulcerative colitis mostly affect mucosa and submucosa. Only occasionally this disease process can extend into muscular layer and serosal layer, and that would be actually a complication of ulcerative colitis, but mostly disease is confined to mucosa and submucosa. Whereas in Crohn's disease, it affects all 4 layers: mucosa, submucosa, muscular layer, serosa. Not only that, it extends actually beyond intestine. It affects mesentery, mesenteric lymph nodes and lymphatics and all the systems. So I think this is the basic difference. And then there's something called skip lesion or stricture formation, fistulae formation, and perianal disease. None of these things are present in ulcerative colitis. Maybe occasionally strictures may be formed, but none other thing like skip lesion. Skip lesion means that one part of gut is affected, then we have normal gut, and then again another patch which is affected. In ulcerative colitis, the disease is contiguous, starting from the rectum going up to any level. But in Crohn's disease, there could be a patch of involvement in one part, and then there's a normal colon, and then another lesion like that. So you could have skip lesion. And Crohn's disease is known to cause stricture formation because it is granulomatous inflammation. It would cause fibrosis and narrowing, and it is also known to cause fistula formation. In fact, it is also called fistula forming disease, and fistula can develop into any two viscera, and I'll discuss this more in the Crohn's disease lecture. And perianal disease. So in Crohn's disease, in up to 50% of the cases, if you examine perianal region, there is likely to be some sinus, some abscess, or something like that. Colonoscopy in ulcerative colitis is usually diagnostic. If you have a careful colonoscopic examination with biopsy, a well-prepared patient, so this will clearly confirm the diagnosis or rule out ulcerative colitis. Whereas colonoscopy may not be helpful in Crohn's disease because it would not rule out small intestinal disease. And then extrahepatic manifestations like erythema nodosum, sclerosing cholangitis, ankylosing spondylitis, and other conditions, and scleritis and uveitis. I think these conditions are possible in both. Some lesions may be more characteristic of one, like erythema, pyoderma gangrenosum is, I think, more commonly seen in ulcerative colitis. Malignancy is possible in both the conditions. To my understanding, more common in ulcerative colitis because colon cancer is otherwise much commoner than small intestinal cancer. So there would be increased incidence of this colon cancer. So that is why all those patients who have long-standing IBD, they require surveillance endoscopy. Maybe after 10 years of their disease, everybody should have annual colonoscopy. Colectomy may be curative in patient with ulcerative colitis because there's only one segment of the colon that is affected, and if we remove that, patient gets cured. Of course, there will be some residual symptom due to colectomy itself, but the disease, the ulcerative colitis, gets cured. Whereas in Crohn's disease, surgery is usually not curative because you could only remove one lesion, other lesions still there, and there is high chance of relapse. So surgery is usually not our main option in Crohn's disease, and of course it is the last option in ulcerative colitis also. So these are some of the differences, but I am going to discuss them in greater detail when I take up ulcerative colitis and Crohn's disease separately. So there are some common symptoms. Just imagine somebody has inflammation of large or small gut. What kind of symptom that patient would have? I think any intestinal symptom you can imagine this patient may have. Patient usually have diarrhea and is chronic crampy diarrhea, and there may be phase of constipation, or there may be blood or mucus in the stool. There may be bloating, and there may be abdominal pain, and there may be tenesmus, that is the feeling of incomplete evacuation, the constant discomfort in the rectum even after passing stool. If patient has this feeling, that means there is inflammation of the rectum. Weight loss, of course, these patients, they have chronic inflammatory state and their food intake may also be reduced, so they could have this weight loss, and they may also present with fever of unknown origin. Palpable masses, more commonly in Crohn's disease than in ulcerative colitis, and there may be extra-intestinal manifestation. This may not be the complete list, but I think these are the main symptoms. So any symptom related to gut may be the symptom of this inflammatory bowel disease. In Crohn's disease, additionally, there may be oral ulcer, there may be dysphagia. So I think all those kinds of symptoms you need to consider. And differential diagnosis, I think I have divided this into two groups. First, differential diagnosis means that you have to differentiate IBD from other intestinal diseases. This part I have briefly discussed, but I'm going to discuss more in detail in the next lecture. But other diseases which have to be ruled out. So whenever we consider IBD, we of course try to look for the signs of IBD, but at the same time, I think we must rule out more common conditions. These conditions are definitely more common. So IBS is definitely maybe I think 10 times commoner than IBD. Celiac disease is common. GRDS, particularly in our country, is common. GRDS intestinalis, and it could cause actually malabsorption. Amoebiasis could become chronic tuberculosis of intestine. In fact, this is the very close differential of Crohn's disease, because tuberculosis also causes granulomatous inflammation of terminal ileum. It could also cause mesenteric hypertrophy. It could also cause mesenteric lymphadenopathy, the features of Crohn's disease. So tuberculosis of intestine would be very close differential diagnosis of Crohn's disease, diverticulosis, and short gut syndrome. Any condition where there is a short gut because of previous surgery or other things, there could be symptoms similar to IBD. So our approach is first to rule out common conditions. Particularly if I have to identify two out of these, I think IBS and celiac disease are fairly common. So these have to be ruled out. These common infections have to be treated before we consider IBD, because IBD requires long-term, if not lifelong treatment. So we must rule out these conditions before we undertake this journey of long-term treatment. And in a second step, after ruling out other infections, then we differentiate between ulcerative colitis and Crohn's disease, and this I've already covered. We like to rule out, differentiate between IBD and ulcerative colitis, which I showed you earlier. And now I'm going to talk about the natural history. Natural history of this disease. First of all, the typical history of IBD is chronic symptomatology with relapses and remission. So this is the relapse and this is remission, relapse and remission with variable time intervals, and this is of course modified by the medication. Now if patient has got a relapse, it could resolve spontaneous also, but with medication it might resolve earlier, and then patient maintains on medication. And if patient is maintaining on medication, still that patient can have relapse. But if patient has discontinued medication, then there are more chances that there will be relapse. So typically this is the history. But in some cases, the patient, they develop the symptomatology and never go into complete remission. So you do whatever you can, but patient continue to have symptoms, particularly if not using biologicals. So if with conventional treatment, at least, there are people who never go into remission. So they continue their symptoms. And then there's another group, they present with acute attack. So in acute diarrheas, we normally do not consider IBD, but if there is acute diarrhea which does not settle and we investigate, we might find that this is actually ulcerative colitis, and this patient goes into remission and then never develop a relapse. So much so that we then start doubting, was it really ulcerative colitis? Now please remember, many patients with ulcerative colitis that do not have ulcers, and this would be more true in ulcerative colitis than Crohn's disease. I think this may be more true in Crohn's disease. So all three variants are possible. The management principles are the same in both groups. These are the management approaches. I would discuss them in more detail in the next video. So there are dietary advices, and many times patient would have identified certain diets uh, which are causing increase in symptoms, so patient can avoid them. And but I think dairy products, what we know is dairy products are more likely to precipitate symptoms, so patient may avoid dairy products. Or we also offer symptomatic treatment like anti-diarrheals and anti-spasmodic. To control diarrhea, we can give anti-diarrheal, but we do not want to stop their diarrhea completely, because that might increase the risk of paralytic ileus. So we just want to make them less symptomatic by giving moderate dose of antidiarrheals, and then antispasmodic to relieve abdominal pain as and when necessary. So, and then we try to give some disease modifying agents. This will be discussed in the next lecture. There are certain conventional immunosuppressant drugs, immunomodulating, and neuro drugs, which are more specific, particularly in Crohn's disease. So they can be given, and there may be some role of antibiotics also, particularly in Crohn's disease in the acute phase, because in Crohn's disease there may be deep ulcers, and that could cause infection, superadded bacterial infection due to intestinal pathogens. In intestine we have anaerobes, we have gram-negative bacteria, so accordingly we give metronidazole and ciprofloxacin, but only to treat acute phase. Antibiotics are usually not recommended on long term. And in ulcerative colitis, mostly they are not recommended, but if you suspect superadded infection, which is possible actually, if there are actually open ulcer in the colon, and colon is normally full of bacteria, so there is a possibility of superadded bacterial infection, you would like to give a course of antibiotic. Then surgery in ulcerative colitis, sometimes we have to do hemicolectomy or total colectomy or sometimes removal of just the distal part, but of course that is not in my scope. But in Crohn's disease, if there is an abscess formation, there is a fistula formation, there may be surgery required to correct that abnormality. So with that, I'd like to thank you for watching this video, and I really look forward to see you in my next video. Please watch other two videos also to complete the module. So I like to see you in my next video on ulcerative colitis and Crohn's disease. Thank you for watching. Professor Aziz Rehman from Medurstand-Understanding Medicine.